Hello, my name is Dr. Shikha Jain. I am a GI medical oncologist at the University of Illinois Cancer Center in Chicago. And today I will be talking about a couple of abstracts from ASCO 2021 focused on colorectal cancer. The four abstracts that I will be briefly touching on are 3500, the KEYNOTE 177 Pembrolizumab versus chemo in MSI-High or MMR deficient metastatic colorectal cancer patients, Fire-4.5, looking at BRAF V600E mutant metastatic colorectal cancer patients, and abstract 3504, discussing the FOCUS4-N Maintenance Capecitabine versus active monitoring for metastatic colorectal cancer patients. So first, to touch briefly on the KEYNOTE 177 study, this particular trial has had results come out previously, but this particular abstract was focusing on the final overall survival data of the phase 3 Pembro versus standard of care chemotherapy study. And what this study concluded was that while we know that pembrolizumab has clinically meaningful and statistically significant improvement in progression-free survival versus chemo in patients who have MSI-High or MMR deficient metastatic colorectal cancer, this study also showed improved safety profiles with a lower incidence of grade 3 treatment-related events in patients who had pembrolizumab as opposed to the chemotherapy. The responses have also been shown to be more durable with pembrolizumab, with an objective response rate of 43.8% versus 33.1%. And one important point to take away from this trial is that there was a high level of crossover. About 60% of patients either crossed over to the pembrolizumab arm or were given PD-1, PD-L1 therapy off trial after progression on chemotherapy. And so the overall survival data was not found to be statistically significant. However, there did seem to be a trend towards improvement in overall survival with the pembrolizumab arm. And it's thought that it is likely that we did not see the statistical significance due to the fact that there was such a high number of crossover in that study. The next study, looking at abstract 3502, looking at FOLFOXIRI plus either Bev or cetuximab as a first-line treatment for BRAF V600E mutant metastatic colorectal cancer. This particular study is the first randomized study really prospectively investigating these mutant patients and whether FOLFOXIRI or cetuximab FOLFOXIRI plus cetuximab or FOLFOXIRI plus Bev would be of the most benefit. What this study concluded was that FOLFOXIRI plus cetuximab did not have a higher objective response rate compared to FOLFOXIRI Bev. However, FOLFOXIRI Bev did seem to induce longer progression-free survival. So the thought was that FOLFOXIRI plus bevacizumab may be preferable to FOLFOXIRI plus cetuximab in the first-line setting. However, more studies are going to need to be done to further assess these patient population. And I think it's really important to note in this study that of 107 treatment patients, only 89 reached 3 cycles of chemo, which really exemplifies the fact that the majority of these patients have an overall poor prognosis. So more is needed to really get a better idea as to what's going to most benefit these patients. And then finally, talking about abstract 3500, this was looking at oral maintenance capecitabine therapy versus active monitoring for patients who had metastatic colorectal cancer who were stable on therapy after 16 weeks of first-line treatment. There have been studies in the past that have shown that there is an improvement in progression-free survival, but not overall survival in patients who are on maintenance therapy as opposed to patients who are on active monitoring. And this particular trial did again show that there was a 3.84-month improvement in progression-free survival in patients who are getting capecitabine maintenance as opposed to those who had a 1.87-month progression-free survival who were in the active monitoring group. However, again, there was not an increase in overall survival or a difference between the two groups, with the active monitoring group actually having a 15.2-month overall survival as compared to the capecitabine group having a 14.8-month overall survival. Again, that was not statistically significant, so there was not a difference in the overall survival in the two arms. There was a higher level of toxicity in the capecitabine arm with more diarrhea and fatigue and stomatitis, as is to be expected. An interesting point is there was no significant difference in the quality of life, despite the fact that there was indeed an increase in the toxicity in the capecitabine arm. So this study did also show that there was improved cost effectiveness in patients who are on the active monitoring arm as opposed to the receiving active treatment. So the conclusion from this particular trial would highlight the fact that while there is an improvement in progression-free survival by maintaining on capecitabine therapy after stable disease after first-line therapy with other agents, it is interesting to note that, again, there is not an improvement in overall survival. There is an increase in toxicity in patients who are on active therapy. And so the thought, again, as supported by other trials that have been done in the past, that there would be a benefit to having periods of time where there's active monitoring ongoing as opposed to continuing active treatment to help mitigate some of those toxicities that we see by continually staying on therapies, and also decreasing the financial toxicity that comes along with being on systemic therapy long-term, as well as having a bit of a mental break from being on long-term chemotherapy. So I think this was a really interesting trial. And I think it, again, supports what has previously been shown, that active monitoring is a reasonable option when it comes to patients with metastatic colorectal cancer who will likely be on some form of therapy at some point long-term. Having these phases of active monitoring will be useful in incorporating into overall standard of practice. Thank you so much for taking the time to listen to some of these updates on metastatic colorectal cancer.